Good afternoon, everybody, and welcome back to BIED's series looking at the intersection of brain injury and domestic violence. I'm Ann McDonald, the Executive Director, and I'm so pleased you're joining us today. This series has been really popular, and before I do another thing, I want to give a great big shout out to Danielle Hill, our occupational therapy student. She and I have been working closely on this project, and she's just done a really great job. Today, we present part 3 in our 4-part series, and we have with us my brilliant, bold, and busy friend, Dr. Kim Gorgens. She's a professor of psychophysiology, clinical neuropsychology, and psychology of criminal behavior at the University of Denver. She manages a large portfolio of TBI-related research and has lectured extensively on those issues. She's done a couple of TED Talks, which are amazing. Look them up. And she's been interviewed in several NPR spots and on CNN with Anderson Cooper. Her work's been featured in U.S. News, Newsweek, Men's Health, Salon.com, and more. She completed a postdoctoral fellowship in clinical neuropsychology, is board certified in rehabilitation psychology, and is the vice president of the American Board of Rehabilitation Psychology. See my earlier comment about busy. I met Kim several years ago at a criminal justice and brain injury summit, and I've been a huge fan of hers ever since. And I was just telling her I was going to warn everybody that she and I are really passionate about brain injury, and we can get a little excited. So just sort of hang on, enjoy the ride, and we're going to have a great conversation today. Today, we're talking about the influence of sex on response to and recovery from brain injury. We are doing this live, so if you have questions for Dr. Gorgens, you can type them into the chat box, and if we have time, I will take a few at the end of the conversation. So welcome, Kim. Thanks very much for joining us.
Oh my gosh, Anne, first of all, thank you for that intro, and this is amazing. I'm so glad we pulled this off to get together. You mentioned that we met a few years ago, but it feels like a lifetime. And everybody watching will know this, but the Brain Injury Alliance of Virginia is really remarkable and setting the pace that the rest of us around the country are trying to keep. And I think this series is incredible. And it's such an honor to share a tiny screen with Trish Smith and Rachel Ramirez and you, my friend. So I'm really excited, and thanks for having me today.
Well, I really wanted to cover this topic as part of the series, because it seems like a majority of the research surrounding brain injury focuses on individuals who are male. But, we know there's a difference. So could you talk a few minutes about the importance of increased attention to female brain injuries and what the research tells us about the different way men and women respond to and recover from brain injury?
This is one of my favorite things to talk about because we know very little in reality, and the research is a little bit all over the place. And as we learn more, we understand just how little we actually know. So as you think about, if you look first at the rates of presentation at emergency departments, this countrywide, what you see is that men are still well overrepresented in the rates of people who are seen for brain injury in hospital settings. Interestingly, though, the rate at which women are seen in emergency room settings has increased 6-fold since 2003. So we're gaining ground, but we're still well underrepresented in the rates of people who seek treatment. There's a little asterisk there, and we can come back to that. But what's really troubling, I think, is what we're beginning to understand about the kinds of injuries that women are sustaining. So interestingly, women are more likely to sustain moderate and severe injuries relative to men. Their rate of mortality is more than 2-fold higher than their male peers. And their risk for longer term problems is much higher. So these are longer term complaints of substance abuse, mental illness, all of the behavioral problems, cognitive and spatial attentional problems. So their risk of poor outcomes is also much higher. Interestingly, women's insight into their deficits is also much greater than it is for their male counterparts. So there's a really kind of interesting opportunity there on the rehab side to deliver services that are likely to land better.
Well, I've listened to some country music in my day, and I'm reminded of an old Tammy Wynette song, the title of which is Stand By Your Man, which is a whole nother thing. But there's a line in that song that says, sometimes it's hard to be a woman.
Right.
Sister, ain't that the truth?
Right. It's so true. And there's lots of positives. So one of the things we talk about when we talk about biological sex and injury, and there's a separate conversation we can have about gender and gender roles and injury and the intersection of those constructs. But one of the things that's really interesting about brain injury in women is the protective role that our sex hormones play in our lifetime. So one of the interesting things is the role of estrogen and progesterone in injury. And it may be that the neuroprotective benefits of those hormones is responsible for the lower rate of women presenting for treatment in emergency departments, that our brains withstand better, less severe injuries.
So how does that sort of flip in terms of us sustaining more moderate to severe injuries? What's the mechanism that flips that?
Isn't that so interesting?
Yeah.
So part of it is that there's this in the research, they operationalize older women, and you'll be horrified to hear this, that it's 30 and up. Which is just absurd.
Great.
So, in any case, the more severe injuries are concentrated in this 30 and up age group. Overrepresented in that age group are a group of women who are perimenopausal, menopausal, postmenopausal. So they have lower circulating levels of estrogen and progesterone.
Okay.
Yeah. Yep.
Well, that makes some sense.
This inverted curve, this perfect U curve, when you look at the rates of injury for women across the lifespan. So much higher pre-adolescence, and then their risk for brain injuries and related dementing disease goes way up as they age, particularly as they hit about 50.
Well, you just said something about related dementing disease. Can you tell us a little bit more about that?
This is so important. And I think this is the conversation that I'm so happy that you're hosting. And I hope that everyone can continue to push for additional attention to. The rate at which women develop dementing disease is twice that of men. So the rate of dementing disease is 2 to 1 for women worldwide. What's really interesting, though, is that there's a unique physiology to women's dementing disease. So on one hand, their brain cells die faster than their male counterparts who also have dementing disease. On the other hand, though, women live longer with dementing disease than their male counterparts. So there's this really interesting space that we really don't understand. What we understand even less about are the ways that women accumulate risk for developing dementing disease across a lifetime. So we've got a great spotlight of attention on the risk for men. Here I'm talking about athletes and military service personnel. There's really terrific research, and our lab is part of that research. So I really appreciate how much ground we've been able to cover identifying these biomarkers, principally in male populations. But we know much less about those same biomarkers or the risk and vulnerabilities for dementing disease among women. And realistically, when you talk about caregiver burden and economic costs, the economic costs of women with dementing disease are much higher because you've also taken out someone who's traditionally playing a caregiver role.
Well, you talk for a minute about how much more we know about men because of football and military service. But, is there a difference between the types of TBIs that are sustained from abuse versus those that are sustained as a participation in sports or the military?
This is so interesting. So it used to be that abuse or violence-related traumatic brain injuries have kind of been an afterthought in brain injury research.
Yeah.
And I've been so excited to see it grab center stage in a growing body of research and really talented researchers. And you've hosted a number of them. So in addition to the obvious psychosocial complications of violence-related TBI, so if you think about the variables that predict prognosis, so someone's security and sense of safety and their access to resources. So all of those factors are compromised. Let's say someone returns to a home that's unsafe. So economic collapse, as someone, let's say they successfully leave an abusive relationship. So So there are a lot of psychosocial complications that make that recovery harder. What is true, though, is for both men and women, violence-related TBIs are associated across the board with much poorer outcomes. Interestingly, in some research, they've tracked economic survivability. And what they found is that particularly for women after violence-related TBI, that they were more likely to be on public sector income at 6 and 12 months than their male peers who had violence-related TBI. So there's something really uniquely hazardous for the overall livelihood of women who are injured in this way. In our research, and we could talk a little bit more about this, but one of my students published her doctoral paper on this, this in a criminal justice population. So these women were incarcerated or somewhere midway through the court system as probationers. And for these women, they were 6 times more likely to have multiple violence-related TBIs. And according to their self-report, they were much sicker. So they described more health conditions, and their self-assessment was that they were more ill. So I made the point in one of my TED Talks that in that way, these women look like retired NFL players without the benefit of foundations supporting research to support them as they get older.
I was going to cite your findings back to you because I thought that was the really interesting thing. In one of the statements that I read, it says almost every single woman in the criminal justice system has been exposed to interpersonal violence and abuse, and more than half of these women have been exposed to repeated brain injuries.
Right.
I think that's one of those really unrecognized, undiagnosed issues that's part of anybody that's involved in the criminal justice system, as some of the work you've done and some of the work that's been done in Virginia has shown.
That's right. That's right. And it's so much more complicated for these women. So not only do they share this history that's otherwise invisible, and I'll just make a quick point about how we're defining multiple brain injuries. So we're getting this from a standardized instrument, and that's women who've been exposed to 2 or more injuries in a short period of time. So usually this is 30 to 60 days. Clinically, we define multiple as sustained a second injury before they'd recovered from the first. But these women are blowing that out of the water, right? These are women who have 5 or 6 injuries a month. So what's interesting, and we've just submitted this, it's under review for publication now, but we looked at our female probationers. So these are folks who are being supported in the community. So if you think about them as, in some ways, being highest risk for failure, psychosocial failure. So we really need to do a good job of surrounding them with the benefits of resources. Interestingly, women with TBI in the probation system reoffend at the same rate that their male peers do. So you don't see that in probation as a whole, where women are much less likely to reoffend. So statistically speaking, they're regarded as very low risk, and they don't have the benefit then of really intensive service delivery. So what we found is that these female probationers look just like their male counterparts in terms of their psychosocial vulnerability, so mental illness, substance abuse, homelessness, and the severity of their symptoms and their risk for reoffense.
I think that's a really interesting point because, women in domestic violence shelters who've been strangled or experienced significant abuse that involves a brain injury look just like the other folks in the shelters that haven't, but they have so many more problems.
That's right.
And so why don't we spend just a couple of minutes talking about that? I remember one of the first presentations that I did on this topic, I was talking about folks with brain injuries, and the folks in the audience who were women who worked in domestic violence shelters thought I was talking about those folks.
That's
and when
right.
I said, no, I'm talking about my folks, I watched light bulbs go off all over them.
Yeah.
So what has your findings shown in terms of the struggles that these women have in trying to receive help because of their brain injury?
So there is a terrific body of research on the prevalence of traumatic brain injury history in populations of women who are help seeking in shelters. There is less research about the overlap between traumatic brain injury related complications and their course through service delivery and criminal justice system. So in this case, right, we're talking about women who are pressing charges and showing up as a witness and delivering statements on time. So we just launched a project, my colleague and I, Anne DePrince, who is one of the foremost, most preeminent researchers in this area. She's amazing. And I'm super lucky to be part of this project with her. So we've got a current project with our partners at the Rose Andom Center here in Denver, which is a kind of all under one roof center for victims of interpersonal violence, so childcare and housing and mental health, and Denver Health has an office there for to support people's physical health. So in any case, we have a project there looking at not only brain injury history, but also cognitive function and trauma-related symptoms. So we're going to track that and service usage over time. The new project that we're launching, though, is to map that onto official judicial records. So we can look and see the degree to which cognitive deficits or emotional problems, trauma-related symptoms, predict in some way failure to access the system. So one of the things that our colleagues who work in shelters are frustrated by, and this also for DAs and anyone in the justice system will tell you that these women, they have a hard time engaging them in the system. So we think about transportation and childcare and all of the complicated reasons that it's harder to get these women into the system and to stick, but there may also be a brain injury related cognitive component to that, kind of managing the calendar of appointments and deadlines and appearances and who do I need to file this order of protection with? And didn't you say this goes there? And, did I need to mail a second copy? Exactly. So my assumption is that there may be a really robust cognitive component of that. The good news, if we find that to be true, is that that's really fixable, right? We can accommodate cognitive deficits in that model as women move through the system. And the trauma symptoms, we know that that plays a role already. So we've got that. We'll track that in our research too.
Well, I'm really excited. One of the initiatives that we've got going in Virginia is that we've just been notified we're getting a grant to screen and intervene. So we're going to work with 4 domestic violence shelters to make them more aware of the issue, because once you know what it is, you can treat it appropriately. Right. One of the things that I've said for years about undiagnosed brain injury is if you're not treating for the right thing, you're not going to get better. It's like giving cancer drugs to a diabetes patient.
Right, that's right.
So once we know what we're dealing with, as you said, there are strategies, there are medications, there are counseling techniques, there are any number of things that can improve the situation. So what we're hoping in this grant is that we'll be able to work with these domestic violence shelters to screen women over a period of time and have a local technical assistance source who may be able to provide some community-based case management, who may be able to provide some technical assistance on how to help these women remember their appointments or get control of their emotions or, follow the shelter rules, any of the things that these ladies can have trouble with. And we're hoping to demonstrate that intervening makes a real difference in the trajectory of their recovery and their success in life later on. And so we're just really excited about the possibility. We see this model working in other ways too. We're going to start with, urban areas. And if that doesn't work, we're going to go to rural areas. Right. We're going to see how that works differently. And then if that doesn't, when that pans out, we may decide to do something, as you mentioned earlier, in the homeless population. Wayne Gorgens said years ago that brain injury is the hidden cause of social failure. Yeah. And when we start connecting the dots for people, don't our eyes get opened in a big way?
That's so right on. And Anne, I just want to point out something I love so much about your programming is that you've always been really committed to building a comprehensive net. So just when you mentioned the rural service delivery, like your commitment isn't only to certain populations, but you've always got an eye on statewide service delivery. So Virginia's where it's at, just saying.
I'm a woman on a mission, man. My thing is brain injury, as it is for you. And if we can do something to make the life a little bit better for somebody and the people who love them and care for them and support, then, the job's a good one, to quote the British, you know,
right.
The job's a good one. I learned that on the Great British Baking Show. That phrase. So Kim, you know, I don't know if there's anything else. You've done such great research in the field of brain injury and criminal justice and getting started in this whole domestic violence field. I don't know if there's anything that I haven't asked you that you'd like to share with folks who are talking just consistently on our chat about what great information this is.
I love that. And I just want to reiterate the point about this conversation. Opening the dialogue is really, I think, the solution to funding research, to getting researcher attention, to getting politician attention, to getting the attention of other policymakers. That the more we can create a groundswell of need and to highlight that need, the better we're all going to be. And I was at a conference, this was years ago. I won't mention names, but this was with two of, I would say, probably the two leading sport concussion researchers in the country, arguably around the world. And they were presenting a lot of their research, which was on male athletes. And I, of course, was the, nudge in the audience who was like, okay, well, I've got a question for you. How do these data, so they were talking about recovery curves, and they've published on those 7 to 14 days, right, return to symptom-free baseline. And I asked, well, how do these data apply to female athletes? And they were honestly baffled that I thought those results might be any different. And that's what we have to battle in the field, is this assumption that the research we have on men applies unilaterally to women, and we need to create a really robust curiosity around the unique experience of women. So from a physiological, genetic standpoint, but also from a psychosocial standpoint, right? Everything about our experience, and this is a little bit more around the gender differences, it's unique and warrants attention. And like I said, we've got to press for it, and we're starting to see the fruits of those labors.
Well, I think it's really funny that you say that, this movement to become more aware of women isn't just in, this field. It's sort of all across the board in terms of how men and women approach topics differently, how our brains work differently from the get-go. You know, there are very obvious sex and gender differences.
That's right.
And if we don't acknowledge that in the research, we're not doing our job.
That's right.
And I'm so delighted to see that smart people like you are thinking about this and asking tough questions and baffling researchers on a daily basis.
That's the best. Well, you can count on me doing my part to do that.
Well, me and you together, babe, we're two women who question authority.
Exactly.
Yeah. So I think that, there's a lot more that needs to be said and done on this topic. I'm really excited to be adding to the body of literature on it. I think that BIAV is on the cusp of some interesting findings, and maybe a model that can be replicated in other states. I think that you're speaking about the advocacy needs. We need to find things that are low cost, high impact interventions that can prove the benefit and the value. Because once we do that, as we know, data drives funding, drives policies, drives services.
That's right.
Yeah.
And we're talking about all of those things. So you're taking the lead, we're following it, and that's where the real change will happen.
Well, thank you so much, Kim. This has been just a great conversation. We could go on for hours, I know, but we said it was only going to be a 20 to 25-minute conversation, so we're there. Kim's been kind enough to give me permission to hand out her email address, so go back to our Facebook page, and you can find that there. If you've missed previous conversations on the topic, you can find them on the videos link on our Facebook tab. And so the first one was with Trish, who Kim mentioned. She gave us an overview, and then Rachel talked about some of the research. The next one will be next week, and Danielle is going to interview me about some screening tools that are easily accessible, easy to use, and that I've been preaching the gospel on for the last 20 some years. And so we'll see what happens when we finish up the series and our grant project, but look for big and better things from Dr. Gorgens and that project that she's working on with Anne DePrince. I've seen some of the initial work and hypotheses, and I'm really looking forward to more of it. So until then, everybody, take care of yourselves and take care of each other. And thanks so much.
And thank you. Thanks to Danielle, too.